Before I leave the stage, I just wanted to introduce our next panel, which is Taking in the Big Picture. I'm not going to read the rest of the title. I think it's in your program, but thank you very much, and let's start with day 2.
Well, good morning, everybody. How's our energy this morning? Yeah. I heard dinner went a little late, so maybe there's some laggards this morning. Hopefully you had a good time, an opportunity to connect. I have to admit, we were talking about this in the green room, it's kind of weird to be seen. Yeah. It's one thing to know faces and be familiar with names. It's a whole other thing to be around people again. And there's something very unnerving but also therapeutic about that, which interestingly enough is going to lead us into our discussion today about how we can meet people in those moments where they are. So my name is Ben Miller. I'm the president of Wellbeing Trust. We're a national foundation focused on advancing a lot of things that you all care about. And it's an honor to be your moderator today. We really have 3 goals for this panel, and we have an all-star cast here. These are some of the best thinkers in the country on the topic du jour. But our 3 goals and kind of what we want to make sure that we walk away with today is, 1, we want to really consider how we can all be collectively informed on what's happening out there for 988 in crisis. Second, we really want to go into the opportunities. How can we explore the opportunities that are happening deep within community, that are both happening at the national, state, and local level? And then finally, and this might put some of you to sleep, but it's the one I probably the most excited about, how do we consider how to finance this? The payment piece. I think a gentleman earlier said, the federal government's not going to save us here. The government's not going to save us here. Well, there's a role here for us to discuss the financing and how and who and where and what. So with that, I will introduce our esteemed panel here, and then we'll get going. I'm going to begin right here with Angela Kimball, who has got a brand new title, so I have to look at it. Senior Vice President of Advocacy and Public Policy for Inseparable. Angela, great to have you here. Next, we have Laura Evans, who's the Director for National and State Policy for Vibrant Emotional Health. Next to her, we have Dr. Chuck Browning, who's the Chief Medical Officer for RI International and the Medical Director for Behavioral Health Link. And then on the end, we have Tiffany Russell, who's the Project Director for Mental Health and Justice Initiative at the Pew Charitable Trust. So thank you all for being here. So, Angela, you get to kick us off here with probably the most 30,000-foot question I could ask anybody. But it's this. When we consider what's happening, a lot of folks in this room know about 988. Could you just start by giving us that massive macro overview of where we are with 988 in this country and why it's so important?
Absolutely. It's a great question. So as probably everybody in this audience knows, 988 was passed into legislation just over a year ago, so October of last year. And essentially, 988 is just a number. But I think what's so critically important here is that it's an opportunity to change the conversation, to change the expectations, and most urgently, to change the experience of care for everyone who experiences a crisis. And this is so critically important for a couple of reasons. As you know, there is a behavioral health crisis in this country. In the last year, over 100,000 people died of overdose deaths for the first time. We have tens of thousands of people dying by suicide every single year. It's the second leading cause of death for youth and young adults. And we have skyrocketing rates of anxiety and depression. And what's really astonishing here is that the percentage of children going to emergency departments for mental health crises, including suicide attempts, in the last year just increased exponentially, 24% to 31%. 24% for the younger kids, 31% for older youth. That's really astonishing. So we are living in an environment of a behavioral health crisis that has been made, as people have pointed out, much worse by the isolation and all the other intended challenges of the pandemic. But on top of that, we also have an existing crisis response system that is completely unacceptable in this country. So the reality is, for most people who experience a behavioral health crisis, law enforcement is the most likely person somebody will interact with, instead of a behavioral health professional or somebody well-trained in crisis response. So we know that so many people, and I'm grateful to the National Suicide Prevention Lifeline for this, are helped by the Lifeline and by other crisis services. But for too many, that's not the case. Instead, they get law enforcement. And that results in arrests, in homelessness, in avoidable emergency department visits, hospitalizations, and worse, trauma and even deaths at the hands of law enforcement encounters. And what's really just shocking is 1 in 4 fatal police shootings in this country are of a person with mental illness. 1 in 3 of those are people of color. That is tragic. So here we have this scenario where we have a behavioral health crisis across the country. We have an inadequate crisis response system, and people are dying instead of getting the help they need. But what's really fortunate is that we now also have a framework for how to help people better. So I think what's important is 988 allows us to have this conversation about how crisis response could be different. And I'm really grateful to Dr. Anita Everett of SAMHSA, who coined some very simple language to talk about this framework. And the first component of a crisis response system is really someone to answer the call. Somebody to come help, someplace to go for care. And when we talk about someone to answer the call, we're talking about 24/7 call centers that have trained staff that can answer a range of behavioral health crisis calls, connect people to services, dispatch mobile crisis teams. When we talk about somebody to come help, we're talking about mobile crisis teams in general, and there's a lot of different flavors of those. But at their core, they are about meeting a person where they're at, establishing rapport, engaging people in services and supports, and helping people on a path to recovery. And when we talk about someplace to go, we're talking about a range of crisis stabilization options. And that needs to include peer supports, as was mentioned earlier. It's about getting somebody in a place where they can get connected to either more intensive services or alternatively to community-based care. Whatever is going to meet their needs, we need that follow-up. So that's a simplification, but what I want to say is this is really an opportunity to change the conversation and get the kind of care that everybody in this country, no matter who they are, where they live, or what their age is, deserves.
Well said. Thank you, Angela. And just to contextualize some of the data that Angela just went over, if you just consider over the course of the next hour while we're in here, roughly 30 folks in this country will die by drugs, alcohol, or suicide. Okay, 30 people, about a person every 3 minutes or so. Okay, this is our moment to do something there, but we know that the system is at capacity. And so, Laura, I want to come to you, and I want to talk a little bit about how the system is already stressed so much. And as you all are doing such a wonderful job with the Lifeline managing this, how do you envision the rollout of 988 going? And talk a little bit about the transition to 988 and the overall implementation strategy.
Yes, thank you. And I want to spend a little bit of time on the Lifeline, the National Suicide Prevention Lifeline, because I want to help folks understand what that network is. So Vibrant Emotional Health is the administrator of the National Suicide Prevention Lifeline. It was started in 2005 to reach anyone, anywhere, anytime in the US to ensure that they had access to emotional support and suicide prevention resources. And while it has suicide prevention in the name, the vast majority of our calls are kind of general mental health emergencies. So we want to make sure that as we're transitioning from 1-800-273-TALK to 988, that folks are aware of the resources and the support that is provided. And so if you think about if you're just a regular person, trying to remember 1-800-273-TALK is pretty hard, you know? And if you're in a mental health emergency, if your loved one is in a mental health emergency, it's impossible to remember. So we're very excited at the promise, as Angela mentioned, of 988 to allow more people to reach the Lifeline, because that's a proven resource that already works. We know that is an effective intervention for people who are in mental health emergencies. So as we're rolling through this transition, it's not just about the phone number, although it is the core of connection to the rest of the continuum and a large front door for folks to enter when they are in crisis. We do want to make sure that, as Angela mentioned, that for people who do need additional services, we do have those connected pieces so that the crisis centers are able to connect to the mobile crisis teams. The mobile crisis teams are able to take someone to a stabilization unit. And so the crisis center isn't dependent on 911 being the only option in that community. And so there are over 180 independently owned and operated crisis centers that are part of the Lifeline network, serving local communities, engaging with individuals who are likely engaging in other ways with the mental health, criminal justice system. And so we want to kind of put that focus on that intervention being a diversion from 80 to 98% of most people who call. So currently, 98% of calls coming into the Lifeline are resolved on the phone. So that individual's distress is de-escalated, they're walked through that moment, and they don't need to call a mobile crisis team. We have prevented law enforcement from going out. But for those 2% or so of folks, we want to make sure that is a mental health approach and not a law enforcement or criminal justice approach. So that's the Lifeline at its core, and that is when someone calls or texts 988 starting in July 2022, July 16, 2022, that's what they will reach. That is the service that currently exists in every state, all communities. And so as we're working on this transition, Vibrant realized that we couldn't just focus on the someone to call piece, but needed to help states have the space to think about how to connect their continuum. So Vibrant funded state 988 planning grants that were awarded. They were open to all states, but 46 states applied and received them in 3 territories. And it allowed states to bring everyone to the table. So bring the mental health community, the lived experience community, the public safety community, bring together advocates and say, do a landscape analysis. What is the situation in our state? Let's start there. Where are the gaps? What are the array of crisis services offered? And how can we do this better? Taking that input from all communities. And so we're very pleased that states have submitted plans, and hopefully those plans will be used to inform policy, right? Because then that will drive a lot of these changes that we're starting to talk about. So we're very excited about that. And we just see this both as kind of the number, making people more aware of the Lifeline and its services, but also ensuring that we are working with that whole person throughout the continuum.
I'm really glad you brought up this point around planning, because I think anytime you begin to implement something without a plan, it could go any number of ways. I remember years ago, we used to work with primary care practices on integrating new measures like depression screening and et cetera. And I was always shocked at how little planning went into something that was so simple. And it would take 4 to 6 months sometimes for a practice just to have one new measure that they began to use. So when we talk about something at this scale, and Chuck, I'm going to come to you on this, it requires a lot of planning. It also requires a lot of understanding around what goes into the details for implementation. So you get to travel around. We were joking in the green room about, you've been a couple of places that none of us have been yet. How are you seeing this stuff roll out? And what are the details that are going into some of the planning and implementation that you think we should all be aware of?
Well, we're very fortunate to be working with different states, counties, and communities that are working on implementation of 988, but then all the services that go with it. And I'm just most excited about the hope and the momentum, opportunity of what this could mean. I've been doing this in my career, for my whole career, working in crisis, and it's like the first time ever that crisis is super cool. And so everybody, there's like, to be able to talk about it and the excitement in different pockets of areas, whether it's the American Association of Emergency Psychiatry or coming here, there's all these different areas that are working on it. As Angela described in those 3 layers, at its core, we have an opportunity to create an equivalent in behavioral health for emergency medical services. A 911 equivalent, an EMS paramedic equivalent, and an emergency department equivalent that serves all And that hopefully once we have that in place, what we're seeing people work towards is so I'll give you just some details and examples of some cool things that are happening. One of the things that I see that I think is really neat is involving people outside of mental health. A county in California involving a systems engineer to look at the workflows and to look at it from that lens. It changes the whole dynamic when someone comes in with that expertise, because how you create that system is how the system's gonna work. I think one of the other important details is seeing communities that are really taking the time to get voice from folks from lived experience, families, communities of color, people who have been and walked in those shoes to help think about how that design, as well as just as we talked about yesterday, taking a look at history. 911 has gone through a lot of challenges in its development, and we're gonna have challenges with 988, but at least if we take the time and places that take the time to look at that, I think that's important. I think the future for research in this is, you think about 911, I mean, when we go now, this wasn't always the case in emergency medical services, but now if you have a stroke or chest pain or things like that, there are protocols that are designed based on evidence-based practices of sharing information, of doing things in a standardized way across the country, collecting that information, managing that data, and giving recommendations about what works and what doesn't. And we have the opportunity through a countrywide rollout and work on this of sharing data, and there's pieces coming together to start to do that. So a lot of different things coming together. I think one of the challenges we talked about the pandemic and it being such a tough thing to wrap our heads around. One positive from the pandemic is the advance it pushed in technology. And that offers a great chance for us to overcome some of the hurdles that we'll be talking about, like dealing with frontier and rural areas, as well as workforce shortages and how do you get expertise for IDD or child or adolescent crisis when a mobile team is out in a rural area 2 hours away from a nearest hospital. So there's things like that that are moving and shaking around. And then finally, I think that there is the greatest consensus that I've ever seen towards an agreement in most areas about the importance of, hey, there's a continuum of care for crisis, but you have to have those 3 core elements in your area to serve people that way. And so we're going to talk about some of the challenges and some of the variations. And if you've seen one community doing it, you've seen one community, because everybody has their own variation of how they're going to do those 3 things. But I think one of the most important exciting developments is it really does create an opportunity, if done correctly, to intercept calls at that 988 line, and so that law enforcement doesn't have to be the folks to come out in the community if needed. So you first have, Laura, like the de-escalation path,
right.
But then for people who do need something more, if you have the right coordination with the technology and the availability of mobile teams, you have an ability to send non-law enforcement response to people for the first time ever and be able to kind of keep people on the zero sequential intercept part of this map so that that's not an involvement, and you actually can help people connect to that. And then the last thing I'll say, based on what Harvey had brought up, is that there is a part of the National Toolkit for Behavioral Health Crisis. There's these essential care practices that are recommended for the crisis continuum, and that all 3 layers should use it. One of those really important things is a recovery-oriented approach with heavy use of peer support. And so it's going to be such an important solution to staffing concerns about this, but it's also going to be so important to help de-escalate crisis in the right way. And I think further research will bear fruit on that too as we go forward.
You said something really important that I think we need to flag, and Tiffany, I'm going to come to you on this point, and that is that you said engaging people outside of mental health. And I don't think anybody in this room would probably disagree with this, but if we only rely on the mental health system to address these issues that are going to come through the pipeline for 988, then we're failing. We have to look at this as a multi-tiered, multi-system response. So Tiffany, when we talk about this, there's criminal justice involvement, there's education involvement, there's healthcare involvement, there's a lot of pieces there. What strategies would you recommend that we consider here when we begin to talk about that integration and that coordination across the systems?
Well, I think the first thing we need to think about is, in history, we've learned that whenever we try to do something in a silo, it always falls on its face, right? We've seen this more than once. We try to work through one thing, through one agency, one department, one system, and it fails. And then we all come back together, we sit at the table and we go, how do we fix it now? why don't we have that conversation at the beginning? At the beginning, when we're planning, when we're doing the implementation, let's have that conversation of who all needs to be at the table. And Ben, you were absolutely right. This is not a mental health system problem that they need to solve on their own. Mental health affects so many systems. It affects your education system, your justice system, your healthcare system. And all of those partners need to be at the table when you're having these conversations about 988 and its implementation and how it affects the current system as it stands right now. So when you're thinking about that, having all of those partners at the table is really going to be integral in its success. I think the second thing we also have to think about is how do we fund that, or how the cost impact on those systems. This is not just something that the mental health system has to pay for, because once it fails, it impacts the justice system, it impacts your education system. I think it's the state of Maryland. They were one of the very first actors in putting together implementation plans for new crisis services that were available through federal funding. And it was the education system that was leading that effort. It wasn't the mental health professionals. It wasn't your justice system. It was your education system putting together social workers that were going to be available in your school systems. And my first thought was, why is the education system taking the lead on that? But it's because they wanted to be able to provide those services because they know that's what their children needed. And they're with your children 8 hours a day. And so if we don't have those services available, are we really sure that they will have access to it? But again, there's no collaboration amongst all of those partners in certain places. I've talked to health associations or health organizations, hospitals, and I say, "What have you heard about 988? Are you planning with your state implementation group about 988?" And there's this strange look. Of course, it's on Zoom, so everything can be strange, but they have this look of confusion on their face, like, I'm not sure what you're talking about. And then I go into a spiel about 988, and I don't feel like I'm the right person to have that conversation with them. And they go, "Oh, I should reach out, and that sounds great. Like we should do more around that." But if I hadn't had that conversation with them, how would they have known? Again, we're working and operating in silos. Our justice system is the same way. We know that when all of the justice partners don't talk to each other, and we realize the impact that we have on each other, the impact or the outcomes are so much greater when we sit down and have those conversations early on, when we sit down and have those conversations about how we're going to pay for it, when we think about the changes that are needed at the policy level. We've been talking to our federal partners, and they're not talking to each other. You have certain agencies that are working in their own silos about 988 and the impact of 988 on their system very specifically, and they're looking at the funding strategies related to those their system independently, but not thinking about the trickle-down effect that you have and the impact that these systems have on each other. And it's really a little frightening when you think about that and you don't think about the outcomes at the end, specifically for the people that are going to be impacted because we were not collaborative at the front end. And I definitely think and feel that a lot of the people leading the effort for 988 really do have the best of intentions, and they're really wanting to see a change and they want to see the impact. But if you put all of those people who feel so strongly about it in the same place at the same time with that same synergy, we could accomplish so much more.
Well said. I think it's probably an understatement of the entire conference for me to say what I'm about to say, but based on what you just mentioned, there's a lot at stake here.
There is.
And we were talking just briefly earlier, and it feels like one of the most important things that's at stake is the trust of the public. That we could get this wrong, and Chuck, I'm going to come to you on this. We could get this wrong and lose the trust of individuals who may never call that number again because of what transpires subsequent to their calling. So Chuck, not to be totally doomsday scenario here, but what happens if we get this wrong?
Well, as you can tell, I like to talk about hope and the momentum. But there's a lot at stake.
Yeah.
It's the reality is this is such an innovation and such a change in the way we're thinking about this. I mean, behavioral health emergency services are where medical emergency services were in 1967. And it didn't just happen overnight, that those things have evolved to some of the levels where we've talked about. Mm-hmm. So what's at stake is if things don't change, the system will be the same, where law enforcement is the de facto group that is left to go out and serve mental health in our communities, because that's the way the system was designed prior to that. And so if the system isn't changed to help support moving in a different direction, we will continue to probably have challenges where people encounter, either choose to not encounter law enforcement by avoiding getting help, and therefore deaths of despair and things of that nature. The second will be that when there is an activation of that the person has a potentially increased risk of going to jail for a nuisance crime or something of that nature, going to an emergency department where they may be boarded for multiple days, and still in a lot of areas in our country, handcuffed to a bed, maybe not even starting treatment because they're waiting to get into an inpatient bed. And so those are some of the doomsday scenarios if we don't change it. But that is, unfortunately, I hate to say it, that is the reality in a lot of parts of our country. So I think in order to deal with that and think through some of the biggest challenges throughout this implementation, when I look at it, are going to be a few major things that I'll mention. Number one will be just any time you have a big innovation and change, is there's resistance between stakeholders that are already somewhat in that space and doing something maybe different. And so we're going to have support and bringing together and engaging and working on, what's the system need to be to help get this accomplished, and have people fill in that part, not hang on to what used to be. Because like I said, what used to be is not that great. It's back in the 60s when you look at where that is. And then I think another piece is going to be workforce. And I mean, when you think about the potential volume of calls that will be coming in through 988, and then the needed number of staffing for those services, for mobile support teams to truly serve an entire state and be able to go out and reach people so that you don't have to send law enforcement out, and then having the staffing to be able to do centers that truly are equivalent to an emergency department, where when people come, they're not too intoxicated, they're not too dangerous, they're not too suicidal. We say, yes, come on in, how can we help support you? When you have those three things, it helps not have the situation that we have currently. And so I think workforce staffing is going to be a big piece. And then finally, just continuing to work, like I said, if you see one state or one community's plan, you've seen one. And so continuing to align in learning communities and collaboratives so that we share information about what's working, what's not working, doing research to help, plan, do a project, record data, what works, what doesn't work, and continue to move forward that. Because we do have some examples of pockets of this being done really well across the country, and how can that all be shared and put together in a system?
Well, Laura, I'm going to come to you about what it means to get this right, and I want to kind of caveat here just a bit. For better or for worse, I oftentimes talk about it and write about how 988 it could be a Trojan horse for mental health reform. That there's a lot of things within it that we need to change already. So I'm wondering if you could just talk about what it means to get it right, and maybe the impact it could have on broader attempts for us to reform mental health in this nation.
Sure. I really like, Chuck, what you said around building on the lessons that we've learned since 1967. And I think that we are kind of on the pathway to doing that. And I think it's also really important to know that on day one, right, July 16th, 2022, all of these changes won't magically already be in place. Right. But we are working, right, to make sure that we are implementing and designing the system, the larger continuum, as it should be. But there are some things that are working, and including, the National Suicide Prevention Lifeline. And that is why it was designated to be the crux through which all calls, chats, and texts to 988 will flow through. And so I think it's really important that sometimes we talk about kind of, the lessons learned from 911 and this is 911 for mental health. And that actually makes me cringe a little bit because it's not at all. When you call 911, you get a menu of options. Do you need fire? Do you need police? Or do you need EMS? Pick one or two. But when you call the Lifeline, when you call 1-800-273-TALK, that is the intervention for most people. For 98% of people who call the Lifeline, that's where it ends. And not because there's nothing else, but because they have been de-escalated. They have walked through their moment of distress. They have been provided emotional support and connected to local resources. So I think it's really important to remember it's not just a relay system to get to mobile crisis teams. Mm-hmm. It's not just a relay system to get to crisis stabilization units. It is the intervention itself. And if we can stop there, at the least restrictive, least costly diversion point, then we are saving the rest of the continuum. So I think it's really, we do need to talk about those larger pieces, but we also need to fortify that first piece. And so those crisis centers around the country are doing amazing work in their local communities, connecting people to support, walking them through their distress. But as I mentioned, most folks aren't aware of the Lifeline. They're not aware of the number. And so as people become aware of the Lifeline and aware of how to reach it through 988 starting in July, we need to make sure there's capacity at those centers. Again, back to workforce. Do they have the capacity to train the workforce to help alleviate distress? That is our first line of defense for folks, and we need to build that capacity. So I think as we talk about broader mental health reform, that really, for me, is the crux of where we go from here, because now we're kind of designing and treating people how they should have always been treated, right? With dignity, respect, and allow the agency and hope for their own future. We don't want to be patriarchal about it. And so I think, keeping people in the community and thriving and preventing emergencies and moving more upstream is so important. But I do think, it's going to take some time. We know what works. We know the Lifeline works. But as we're kind of working on those mobile crisis pieces, it is going to take some time for folks to build out.
Thank you. And it seems like it's also going to take a lot of leadership. I mean, I think this panel is a wonderful example of leaders. Each of you in this room are leaders in your own right. But I want to talk about leadership for a second, because that's one of those variables that it seems like if we don't have as a strong kind of backbone to our plan, then most of this falls apart. It becomes good ideas on paper. But at the end of it, we got to have people that stand up and represent. And so I want to come back to you, Tiffany, and I want to talk about the importance of leadership. And I specifically want to kind of try and tie in here the importance of buy-in from leadership from different sectors. And I know you've done some work with our law enforcement friends. What are they thinking about this? Is this a blessing or a curse? What is the general kind of feeling that leaders outside of the sector have around 988?
Well, I think before we can determine whether they think it's a blessing or a curse, that's an assumption that they know.
Yeah.
And from a lot of the conversations that we've had, they don't know. They don't know what 988 is in general. They don't know that 988 is coming this summer. And it's not from a lack of education efforts by certain entities, mainly like Vibrant and other community, like the community jam call that we have every Wednesday, where we're all learning about this. It's because it's important to us, and we know that if we don't get this right, what that impact will look like. But when you talk to law enforcement, when you think about a law enforcement officer, they operate in assurance and sure, like I'm sure that if I do this, this is going to be the result. This is the way that it should happen, and this is going to be the result. If you're thinking about what happens with 988, we can't answer a lot of questions right now. And so when we sit down and we talk to our law enforcement friends, and they ask us very specific questions, our answer right now is, we don't know. We're still figuring it out. We're still trying to figure out that plan. And for them, their ears shut off immediately. And they're like, all right, well, I'll just have to stand the steed until you guys figure it out, because that's what's been happening for so long. And I think when we've had those conversations with law enforcement, I think, Chuck, there was a call that we were actually on like last week about they're risk averse. And so they know that when you call 911, someone is going to answer 24 days, 24/7, 365 days a week. Someone's going to answer. Not only is someone going to answer, someone is going to come, whether you're in a rural community, whether you're in urban, someone's going to come if you call that number. And when they start hearing about the different intricacies of 988 and the system and how it may work or how it could work, they're lacking that assurity. And that also trickles down to your local government leaders. They know that they can count on the police to do the job that they're supposed to do. And now that we have made crisis response a part of the job that they are there to do, they know that they will go out and respond. And what we've been trying to share with law enforcement agencies as we've been talking over the last year or so is the importance of why they need to be involved in that conversation. And I know that for me, if you want to really get me interested in a conversation, engage with me about how you can take some work off my plate. Or how can you make this easier for me? And if 1/5 of their law enforcement time, and I think that's still a very small number. I think it's much larger than that. But if 1/5 of their time is delegated to crisis response, if you start talking to them about, I'm going to take away from you this responsibility to handle mental health crisis or mental health emergencies in your community, and now you can focus on the job that you were sworn to do, which is public safety and crime prevention or investigation of crime, and you're not part of that response any longer, I may be willing to sit and have a conversation with you to really understand not only what you're trying to do, but how can I help and support you in what you're trying to do. And I think once we get that buy-in from our law enforcement agencies, that the local government will then follow along with us, even though they're bought into the idea of it. But once you can start putting some things in cement about how this is going to work more broadly, then you can really have their buy-in and support.
So Angela, I'm one of these local leaders that Tiffany just described. Okay, I'm mayor of small town, your favorite city, okay? What recommendations would you have for me? And are there examples out there of good that maybe you could point me to say, hey, you know, over there they did this and that might be useful for you to know? Because I hear your point. Like if people don't know and they don't have the vision of what could be, this is all just hypothetical. You know, it remains in this realm of possibility, but let's get tangible here. Like what would you say to me as this leader who's looking at you in the eyes and I'm trying to figure out what in the world to do?
I think one of the most important things for local leaders to think about is first, what is the shared vision and what are shared objectives that everybody can agree on? A lot of times people want to get to the tactics first instead of really focusing on what is it we're trying to achieve. And I think when we focus on the person, that we want an improved experience of care for everyone who experiences a behavioral health emergency. Whether it's mental health, substance use, suicidal, we want a better experience of care. When we think about shared objectives, to get to Tiffany's point, people in different systems are self-interested. They want to know, how is this going to work for me? When we look at the intersection of what's best for the individual and what's best for other systems, then we start to get to shared objectives. So when we think about things like as a local community, can we agree that a sign of success of a new 988 crisis response system is reduced arrests, reduced time waiting in emergency departments, reduced transports? Okay, those are shared objectives. If we talk to school systems and find out what are their pain points, what would success look like for them? Fewer kids arrested in juvenile justice, no cops showing up at the local high school or middle school. If we are talking to healthcare systems, we know emergency departments are incredibly overburdened. So when we talk about what are their pain points, They know they don't have beds to get people into. They're boarding people, and as he pointed out, sometimes handcuffing people to gurneys who are waiting. If we can reduce the number of people who are coming into emergency departments for behavioral health emergencies, that's a shared outcome. So when we can start with that shared vision, shared outcomes, then we can start designing systems. And I think, Chuck, you talked about data. I think data cannot be overstated, because if we agree, here are the data points that will show us whether the system we want is working the way we want it, it allows us to tweak systems. Instead of expecting everything to be perfect on day one, it won't be. So we need to constantly learn within our own systems and from other people. So that's one piece of what leaders can do. Another piece is simply building on local strengths. And sometimes that looks like something that isn't a strength initially. I was really impressed by the state of Pennsylvania looking at their local call center capacity and seeing real gaps in it around the state, and simply working very methodically, kind of like the systems engineer in LA, at here's the map of our state, here are the different call centers, here's where we have problems, and really working to systematically increase capacity and the ability to handle calls in state, locally, hopefully 100% of the time. That's an example of a state taking an incremental step towards getting to the kind of response that we all want to see. And then the last piece is really about building community and building momentum. And one of my favorite state examples of that is a little state that could, Nevada. And I say Nevada because I'm from the West Coast, and that's how we pronounce Nevada, not Nevada, like everybody on the East Coast. And Nevada, the mental health director there, advocates, everybody got together. They believed in a better system, and they passed a bill with a 988 user fee to fund things that this state doesn't have. And Nevada is a state that has been very resource poor when it comes to mental health services, and they want to do it differently. They can do it, we can all do it. And somebody pointed out here earlier, this is up to us. This is really up to us, and we can do it. We need to fight for the system that's going to take care of people and give them a better response.
So well said. I've got a few more questions, but I see we have a question at the mic. I'll turn to you.
Thank you very much. Good morning, and thank you for the very thoughtful conversation. 911 was invented in 1957. By 1985, only half the country was using it. Given the fact that and they had capacity, police and fire already existed. Given the fact that this may take years, if not decades, to become fully implemented, are we already designing an antiquated system that will not be current given the technological changes that Americans are using today? The phone probably we'll all be FaceTiming or Zooming in 15, 20 years. We're barely using phones now. So shouldn't we be thinking about designing a more modern system that's going to be more relevant for what's going to be available then? And why do we need people to go to a facility if they can see a doctor in 2 minutes and maybe get stabilization over the phone and have a follow-up? Thank you.
Thank you. That's a brilliant question. And I think that question is one that we should consider over and over and over again as we begin to talk about the things that we're discussing today. So I want to turn to the panel and see how you would respond to that, because I think on the one hand, absolutely. It's like we were talking about with our youth friends here that are doing a lot of the media work. I don't want to design a system for me. This system needs to be designed for you, because by the time it's implemented, it's you that's using it. So how do we, to use the overused Wayne Gretzky quote, skate to where the puck's going to be?
I'll volunteer to say some things. And a lot of it ties into some of the things I said already. I think technology advances, like I said, are going to potentially change the future, as well as, this is a big innovation realm. And so I think somebody's going to Amazon this over time, and there will be some kind of way to, that's the whole reason Amazon stuff, they come to your home. And so like you're talking about, I think that's an element. However, there probably will always be, and that's the whole essence of this Crisis Now 3 core services, even though there's many more services in the continuum of a crisis, preventative and post, and things of that nature. But at each level is designed to de-escalate so that you serve the majority of people through the call line service. But then people who do need someone to come to them, then those mobile teams in areas where they're really functioning well, again, maybe anywhere from 70 to 85% of those folks don't need to go to another facility. And then places such as like the state of Arizona or some of our places around the country that do this type of 23-hour emergency room service specifically for behavioral health show numbers as high as 70 to 80% of people being able to return to the community in 24 hours or less. So now you're kind of continuing to add in layers. So there will always probably be a need to have a place when people need someone to come to them or there to go. But the greater that we can use technology, and again, my kids, they're so hardwired to be able to do something like that for support in the future. So I think it's brilliant. It's so important to be thinking about that as we do those innovations, how we use it to support.
Chuck, if I could add to that, because I think that's such a phenomenal answer, and it's a really great question. I think we also have to look at the evolution of crisis services historically. So it used to be, in some cases, that you had a state or local line that was open from 9 to 5. So you had to have your crisis or mental health emergency during business hours. If not, you got an answering machine or told to go to the emergency room, which is not helpful and expensive. And so with the creation of the Lifeline, it truly served to be that line that you could call, and again, you can call, text, or chat 24/7, 365, and reach emotional support. So again, we're moving to what is in the best interest of the individual experiencing an emergency. So we're not doing it when it's convenient for us or we're meeting people where they are, and I think that's really important. And as we design a system, we both have to meet the needs of today, but being flexible for what will come tomorrow. We may think we know, but we don't know. We may bet on Zune, but it turned out that the iPod was the, the music player. I'm dating myself here. Right? But we never know what's going to be the new innovation, but we do have to build in that flexibility. And we do have to also match the words that we're saying about reducing stigma with the actual services. So I think we're getting to a point, particularly with the younger generation, that it's less of a stigma. You talk about going to your therapy appointments and you talk about your challenges, but are the services matching that? So, are the services equitable? Are we building the system that will be able to meet them where they are and where they want to go? How do you want to engage with the Lifeline? How do you want the service to look? And I think that's really important to have those discussions here in the local communities through the planning grants and others, so that we're building it for what works in your community, or you're building it for what works in your community.
It's a great point that the most successful companies constantly are reinventing themselves. Google wasn't content to be a search engine. Look what it is now. Okay, and so I think that this is a wonderful challenge that we should embrace throughout our discussions today. Sir, I'm going to come to you on the mic.
Yes, my name is Douglas Reed, Director of Partnerships for Black Men Heal. We give the free therapy to Black men. I am the client, not a therapist. So my question that I impose is, what is there an initiative? Like I hear the initiative from the top down. But is there an initiative from the bottom going up? Me, like being a client within the organization and being an advocate around mental health, same thing with 988. If I walk down the street outside in Philly and there's a homeless guy with mental issues, does he know about 988? Or how do we get that message to them? Once again, maybe using social media, especially now, like nobody watches the news now. TikTok, what initiatives are actually being used to really make sure 988, that message about 988 is getting down to the lowest level?
Thank you for that. I hear two things in your question. I mean, there's the one which is around the messaging and the communication, and I'd love for you all to speak to that. But then there's this first part you started with, which I think is extremely important. How do we avoid telling people this is what has to be done and allow for communities to have flexibility on their own ideas on what could be done. And there's always a tension there. So I appreciate you flagging that. And guys, I'll let any of you take either side of that question.
Well, when I said what's working well, is we are in communities where there are engagements of voice in many different realms to help support. An example would be hearing impaired. And being able to talk about how crisis services might be different for them and the needs that they would have, and taking that and embracing that. And we're seeing communities do learning groups with stakeholders, participating with those who are receiving those services and have an investment in how the community is going to be done. But on the other end, where I said where things could go wrong is by not including that voice and just creating a system and putting it on people. And I hope we learn from history and don't do that. But that's the tension of that in my mind.
Yeah, and I would say, I'm going to go back to our 988 planning grants, because that really was the intent, providing states with the funding and space to have those conversations and to bring people in and to not move so quickly so that we're able to hear what people want so that they're able to drive the conversation. We know from Vibrant, we cannot direct, what all 50 states should do. Because every state is different, every community is different. But we have some overarching goals that should be accomplished. There should be 100% coverage 24/7 for individuals who are reaching out to the Lifeline via call, text, or chat. We need to ensure that the state is coordinating connection with mobile crisis teams and other people who could respond with a public health approach. And then that there's a place to go that's not jail or emergency departments. Those are the core elements, as Angela has talked about. But how each state does that or gets to that may look different, but to give them the space to bring everyone together. And that's why it's so important that we required the lived experience community to be a part of that conversation. We required public safety to be a part of that. We required mental health advocates to be a part of that. There were a lot of requirements, but I think it's so important that we build it from both the bottom up and the top down of, Lifeline. We're building capacity nationally, but also kind of how does the continuum look in your state? That's going to be hyper local.
And maybe it's a role for funders, those as one in this room, that we can consider the second part of your question around the TikTok, the Twitter. How do we begin to really constitute or create programs and information that reaches that generation, the folks using those tools? It's a wonderful point. I'm going to come to you in just a second, but I have to ask one more question to these guys because I'm watching our time and I want to make sure that I get in the financing piece. So I'll come right back to you. Okay, we got to talk about money. Scaling and sustainability are my two favorite words, and none of this happens if we don't figure out the cost of it and how we're going to finance it. So I'm going to do kind of a rapid fire questions here because I want to get to that. But Chuck, I want to start with you. And how much does this cost? Do we have a good idea of estimates in terms of how much it's going to cost to implement a good full continuum of crisis?
There's some estimates. I'm a chief medical officer, not the chief finance officer, so I might mess up these numbers, but I'm hoping I'm going to get them correct. So we have developed a crisis needs calculator that you can see on NashBid's Crisis Now site. It's an open source thing, and you punch in numbers of your community. But if you take an average state of, and I'm saying average of 6.5 million, and again, you can vary the types of services and things you're going to do, but going by that Crisis Now model and carrying it out to fruition and practicing it the way it's recommended to be practiced, then you're talking about 184,000 calls a year, 55 mobile teams, 290 crisis chairs for those 23-hour observation units, just for those three core services to be able to serve that valve flow management. If it's in a Medicaid expanded state where you're going to get a federal match of 56.2%, you're talking about state funds then being more in the about 62 or 64 million range. Now here's the kicker, about half of those are going to go to provide crisis services for people that have Medicare and private commercial insurance. Because if you do true crisis, you're supporting everyone that comes in to your facility or a mobile team or call line. So what you're looking at is, that's one of the issues going forward with funding is parity with Medicare and commercial insurance stepping up to the table like they do for medical emergencies. There is, though, the balance of that, though. There's going to be healthcare savings in emergency room costs, hospital costs, in the judicial system and things of that nature that we think over the long run will still help combat that spend. But that's just based on numbers and that kind of thing. And Vibrant's got a detailed state-by-state plan as well on that.
Yeah, and so Tiffany, really quickly, in terms of cost savings, I mean, I think Chuck just alluded to this. Do we have any estimates or ideas in terms of how much money we save when we actually fully implement this model?
Well, before I mention what the cost savings might look like, I'll always start the conversation by we shouldn't be thinking about how much money we're saving. We should just do it because it's what's right. End of the sentence. So, but when we think about the cost savings that are available with the implementation of 988, there are so many services currently that will be available under 988 that are Medicaid reimbursable. Police are not Medicaid reimbursable. Their response to a crisis is not Medicaid reimbursable. Jail time is not Medicaid reimbursable. And so when you start thinking about the downstream cost of those impact of those systems, that is where you will start to see the savings for the system itself. Less time in jail, less time in emergency rooms. And then when you're also thinking about, additionally, the broader cost that are realized by the people that are receiving end of that system. When you have someone that is in crisis and they end up in a jail or they end up in a hospital, they lose access to housing and jobs, and the cost to the family, the cost to the individual is so much greater than what we're thinking about just for the cost of the system. And so you have generations of people that are still impacted by this improper response, and the cost to the system are just measurable when you start to think about that. But as far as the 988 services, there's a portion of that, and I think in April of 2022, there will be enhancements for Medicaid that will be reimbursable, and then the state has another 15% that they will then be responsible for. But right now, if you think about who is responding to crisis as it stands, the impact and the cost is based solely on states and localities because it's a crisis response that's coming from law enforcement, and you can't reimburse for that time or that effort.
Thank you, well said.
Thank you. So I'm Karis. Hello.
Hey.
Hi, Chuck. So my question really is about, and maybe it's a little bit of a word of caution that leads to a question, is we get excited about technology, but what we found for people in public mental health is there's a different way in which people either have access to and or use technology. So I do worry that if we get all excited about technology and move things towards thinking everybody can get on FaceTime and talk to their doc, that's actually not true. And then when we do give people the technology in order to do that, they actually don't know how to use it. So if we think about, though, the ability to get people the technology and have the bandwidth in order to access things when and where and how they want it, which technology can help you do, how would that be baked into a 988 system so that the train doesn't leave the station and we've left the most vulnerable behind yet again?
Extremely wise words, Karis. Thank you for that, and that's a great point. And I feel like that's an element here that we could discuss more in terms of how to apply the equity lens to assure that we don't leave certain communities behind. How do we make sure that some of the data that we saw from COVID, that those disparities aren't exacerbated through our plan for 988? And I really welcome comments on that, but thank you, Karis, for flagging. Anybody want to just quickly reply to what she said before we go on? And I'm coming to you, sir.
I would just say there are states, like I believe Oklahoma, where they've got iPads that are being used by law enforcement to connect with people on the spot with behavioral health therapists. So that's a way of not relying on the technology and the ability to use it being on the person, but rather on the person who's trying to serve and help. So that's one aspect. I'd also say that, and this is part of a larger question, and that's why we're looking at federal legislation about making broadband more widely available, technology more widely available, and reducing the disparities based on income. Because this is expensive, and we need to make it accessible for everybody, no matter where they live and how much money they make.
Thank you. All right, we have the last question here, and then I'm going to follow up, and we'll be done. Go ahead.
Yeah, you're talking about Grand Lake Community, CCBHC. Yeah, they've solved that problem by providing iPads, single-purpose iPads to all the people that they serve. And they pay for all the data charges, and so people can get care whenever they need it, wherever they are. And they also have iPads that are used by law enforcement to serve their own personal trauma-related needs. But my comment, isn't really a question, was that I'm Robert Shaw with the Nashville Research Institute, and one of the things I've observed over the years is that, related to funding, is that maybe no state, if possible, if there's maybe one or two, but probably no state really knows at a state level what they're funding for mental health. They don't know all the nooks and crannies. It's amazing, all this stuff got developed independently on an ad hoc basis. And then in some states, it's more disparate than that because the crisis service funding comes from the local community and not so much from the state. So.
Yeah, thank you.
Ben, if I could respond to that, because I do want to, and not respond, but just kind of thank you for that point and pointing it out. And it raised a couple of things for me that I want to make sure that I highlight before we end the session. And that is, this is the right thing to do, as Tiffany pointed out. And we need to have all payers, federal, state, private, public, at the table. There's been historic investment in mental health. So we are at the point where we are because we haven't had that investment that's been needed. Crisis centers are also not Medicaid reimbursable. So the people who are answering the phones in those centers are not getting funding from Medicaid, and they're reliant on private funders or scraping by. One of the things that the federal legislation allowed was for states to, much like 911 is funded, have a surcharge or fee on telecommunication points. And phone bills, cell phone bills, landline bills, and that is a way to generate revenue in addition to the other sources. And I was doing research on this, and in 2019, the 911 fee generated over $3 billion in 1 year. Imagine that kind of investment for mental health year over year in addition to those other sources. So I think it's really important that states explore that. That is certainly an option, and wanting to let people know that this is important work. It's going to take some financing changes, but there are options, and we have to have everything on the table, and we have to have everyone at the table.
And I'll follow up on that and say that NAMI did some polling on that and found that the vast majority of people in this country support a 988 fee on their phone bills. And when they know that the average phone bill charge for 911 is $1, they're even more supportive. So we have this reality that people in the country are actually supportive of fees like that. And then back to something Chuck said earlier about we need parity. We also need federal and state legislation that would require all health plans to come to the table and cover crisis services. And there's a bill in Congress, S1902, HR 5611, the Behavioral Health Crisis Expansion Act, which would do that. It would require virtually all health plans to cover mobile crisis teams in the range of crisis stabilization options. That would be huge. And Washington State is planning to introduce a bill to do that in their state. So these are some of the examples of trying to diversify that funding so that we actually have that system that everybody deserves.
Thank you, Angela. So we're at time, but I'm going to give them an opportunity to, in one word, describe what 988 means for the broader mental health and substance use community. So one word, folks, one word, and then we'll close it out. Angela.
Hope. I'm going to say opportunity.
Parity.
Synergy.
Beautiful. Yeah. Give them a hand. Thank you, Melissa.
All right, well, thank you so
so much, wonderful panelists. I'm going to applaud you again. Thank you. This was a really important session. We're next going to go into a discussion about Ohio to see how these issues are playing out in that state, and then later we'll hear from some folks from South Carolina. We had anticipated a 15-minute break. Now I'd like to shorten that to 5 minutes, quick freshen up, and then come on back here. I think that's at 9:50, perhaps 9:51. But we look forward to seeing you in 5 minutes. Thanks again. Great job, everybody. Thank you.
And it's so easy.